Welcome, everybody, to our Advancing Analytics in Children's Hospitals seminar series. I want to thank our panelists ahead of time today. This is a really interesting panel, and I think you're going to really enjoy it. The title of the panel is Visualization Analytics, Pictures More Than P-Values, which probably would pique someone's interest or ire, but we think it's a really interesting way to do some data exploration. So what is really wonderful about what you're going to see today is the result of a collaboration between our clinicians and between one of our clinicians and a data science team at Northwestern University. And I think it's a great example of how analytics only takes us so far. We really have to engage our clinicians in understanding the data and getting it to where it needs to be so it can be helpful to us. So with that, I'm going to go ahead and introduce Renee Manwaring, who is the head of our research, our nursing research area. She's an associate professor of pediatrics at Northwestern, and she's the Posey and Fred Love Chair of Nursing. Renee leads a bunch of research on our nursing, among our nursing area, and also does a lot of mentoring around nursing research. So she's a great asset to our team. So I'm going to have her take off, and as she launches in, she'll introduce the rest of the data science team. So thanks for joining us, and here we go.
Hi. So I'm Renee Manwaring. I'm the Director of Nursing Research. And my research is on pain, which I know every one of you, I'm guessing, feel free to chat or raise your hand if you have never, ever had pain in your life. And then we have specific genetic tests we'd like to do to see why that is, because that would be very unusual. What you probably know about pain is very dynamic. And yet when I look at publications and when people are looking at p-values, they will put the minimum, the maximum, the mean, the median, and it sometimes makes me suspicious if they're just deciding what to use based on p-values, because p-values get published, but does it really help us care for our patients? So I had the opportunity as a faculty member at Northwestern to engage in what's called a TL1 grant. So those of you who have university partners, you may want to see if they have something like this. The Department of Pediatrics has a grant with the Department of Biomedical Engineering and Applied Mathematics. And I was able to submit data, lots of data. Now I say lots of data, but lots of data about 72 patients. So the problem of lots of data about a very small sample. And ask the students to unbiasedly look at the data and help me determine how could we really show the dynamics of pain? How could we really analyze it so it was meaningful and we could do something with it clinically, as opposed to just having a significant p-value. Now, I wanted them to have significant p-values also so we could publish that work, but what you're going to see is some of their creativity. And I want to introduce the next speaker, who is no longer a student at Northwestern. She has graduated with her master's in applied mathematics, but definitely was one of the shining stars when they presented to me their great work and what they did with the data. So this is Naomi Kadewala.
Thank you so much, Renee. Naomi here. As Renee mentioned, I'm now the head of Kavi Labs at Kavi Global, a consulting solutions software company where we partner with a variety of research institutions for R&D, as well as enterprises for cross-functional business analytics solutions across industries. But healthcare has truly always been a passion of mine, and at the intersection of analytics. So prior to this role, I was a founding member of GE Healthcare's analytics team and worked on creating some innovative IoT or connected device solutions with MRI and CT machines. And I met Renee at Northwestern while I was doing my Master's of Science in Analytics, and we have been maintaining our research partnership ever since for over a year now. And that has led us to be here with you all today presenting our findings. So very happy to be here sharing our research and some recommendations. I'll quickly give a shout out to the rest of the Kavi team members up front who will be speaking in today's session. Trishla, a data scientist from our Kavi Labs team. Rajesh, VP of Technology Solutions. And Parthi, a senior healthcare business analytics consultant. And Vijitha, our founder and CEO of Kavi Global. So diving right in, today I will take you through our journey chronologically. First, Renee and I will take you through our initial research at Northwestern, where we looked at some novel approaches to visualize and segment this self-reported patient pain. Then I'll hand it over to Trishla and Renee to walk through some of the research we're doing now with Renee in partnership, Kavi Labs and Renee at Lurie's Children's Hospital. And then we'll wrap up by sharing some of the challenges and limitations that we face throughout in this pain management research. And I'll turn it over to the Kavi team to share some innovative industry data analytics solutions to address each limitation. And I'm sure they'll be relevant to all of you across a variety of other applications. So it should be exciting. So as we mentioned, while I was studying at Northwestern, Renee came to us with an interesting problem. How can we better communicate and analyze, visualize this adolescent patient pain post-surgery? We were eager to take on this challenge and see what insights could we mine for Renee. Now I'll turn it over to Renee for a quick overview of the patient populations we were working with and the painful surgeries they were undergoing.
Thanks. So there are two surgeries we tend to study and that you'll see a lot in the literature on children's pain. And that is patients who've had scoliosis, a curvature of the spine, typically over 50 degrees, and patients who've had pectus excavatum. You can see in the right, the picture of pectus excavatum showing that the sternum is almost pushed all the way to the spine. That's how concave this patient's chest is, and hopefully your chest is not that concave. In fact, the problem with your chest being this concave is, see that little gray blob in the middle there? That's the heart. And you can see that this kid's chest is pushing down on the heart, which may affect the blood flow to the rest of the body, creating fatigue. And in both of these cases, more so in the pre-op scoliosis, but because of the students' work, I was amazed that how many of our pectus excavatum patients complained of pain preoperatively. Why, though, do we study these patients? These patients are in the hospital a significant amount of time. It used to be 7 days. It's now down to about 3 to 4 days. At most maybe 5 days, and so you'll see only a limited sample. Most other patients who have surgery, children who have surgery, go home, and we'll talk about that later on, the big black box of what happens with pain and pain management in patients' home. So here you can see, if you weren't sure that curvature was too painful or that convexity was too painful, this is what we do. All of these patients get hardware, and yes, the scoliosis patient has nuts, bolts, screws, and rods in their back, and they will stay there for as long as we can keep them in. And the patient whose chest, hopefully you can see, looks a lot more normal, has 3 bars. Normally we put in 2 bars, hopefully just 1 bar, holding the sternum up. That surgery is minimally invasive. You can see there's no incision down the center of his spine, whereas the scoliosis surgery, we fillet the patient open from stem to stern. But with this one, it's minimally invasive. They actually have a puncture wound on each side of the chest. However, it's pretty darn painful because they stick those bars in and then they move them from being convex to concave, and it pops the chest out and pops the sternum out. And as you can imagine, everything in their chest pulls, and it takes a while for that pain to go away. You're going to see self-reported scores from 0 to 96 hours on these patients.
Thanks, Renee. So when Renee came to us, she was explaining her frustration when journal publications were looking at mean, median, mode to express patient pain, as we know it's more than a single number. And it really led us to think, are they picking for p-value? We didn't think it makes sense to look at pain in aggregate. So how can we express this dynamic and continuously evolving subjective nature of pain? Time series, or looking at the pain over time, which is what you see on the left here. So Renee was already experimenting with time series data when I met her and plotting this patient pain over time. So what you see on the left is a patient with decreasing pain from 0 to 96 hours post-surgery versus on the right, a patient who's having some volatile kind of increasing pain trajectory post-surgery. But with 63 patients, you end up with a lot of time series charts. It's just like a lot of spaghetti charts. So how to make it actionable, how to segment it and make it meaningful. Well, one option is to group it together by similarity or clustering. So clustering just means to group similar things together, in this case, patients with similar pain trajectories. And the way we can measure similarity between these patients' time series scores or their pain over time is called cross-correlation. And that's what you'll see on the right here. A heat map indicating how similar is each patient to every other patient. 1 meaning they're very similar, 0 meaning they're not very similar, and 1 kind of meaning inversely similar, as the 2 on the left might be. So moving right along, we fed this cross-correlation or the similarity matrix into a clustering algorithm known as hierarchical clustering. And what is it doing? Well, just as the name suggests, the algorithm is building a hierarchy of clusters, starting with each patient or each data point in a cluster of its own, which is what you see at the bottom there at the leaf nodes of the dendrogram. Each patient. Then, based on how similar they are, they begin getting grouped together until there's only one final cluster. Then we need to determine where is the optimal number of clusters, or how can we segment these groups? That's what you see in red. 3 clusters have been identified by looking at the dendrogram. Now let's look at what are the patients within each of these groups and how does their time series pain score look? Wow, do you see something shocking? We can see that it's grouped together all the similar patients. Cluster A being the decreasing pain patients, cluster B being the kind of volatile pain scores or high variance pain, and cluster C indicating the patients that had increasing pain. Great, looks like the clustering worked pretty well. And now we have these 3 distinct groups where we can use for a little bit more personalized treatment for each of these pain groups. Here is the same data that's been clustered, just visualized in a new way, in 3D. We look at this as we like to see how well did the clustering work. It's a kind of evaluation technique. And what we're looking for is that the groups are kind of distinctly segregated out and there's not too much overlap. So it doesn't look too bad, as you can see from the green. Decreasing patients are mostly grouped together and not too much overlap, but a little bit with the high variance, and same with the increasing all the way on the top left. Great, now we wondered, as we only have 63 patients to start, and we broke those now into 3 clusters of 10 to 20 patients, it's very difficult to do a lot of statistical significance testing, but we wanted to look at some of the descriptive visuals on a variety of features or dimensions of the patients grouped by their cluster. We looked at a variety of the patients, their demographic and factors of their care, and we also happened to look on which doctors they had.
Yeah,
so
and this is where I made the ultimate mistake for clinicians or you data scientists who get this kind of information. We've now fixed the slide. It says doc 1, 2, 3, 4. It actually had the doctors' names on it. And as they presented to the entire class, I was horrified when I saw the doctor's name on it. At the same time, Naomi's going to tell you their conclusion. And it probably helped that we knew the names. Go ahead, Naomi.
Yeah, here we were trying to understand why some doctors, like Dr. 1, had no patients in the decreasing pain cluster of patients, but had quite a few in the increasing pain. We wondered, is Dr. 1 perhaps taking on some more complex patients? And whereas Dr. 3, you can see, is not in the increasing pain, but has patients either in the high variance or decreasing. So on the next slide.
Yeah, so what I told the students after they had politely said, we think this doctor is probably taking more complex patients, but they had also analyzed for some measures of complexity, like, and these are just those patients with the convex chest. So they had analyzed what we call a Haller index, which is how severe is that pectus, and that didn't show up, but the doctors did. And as you'll notice, our conclusion is the older the wiser, because what they actually did was prove the learning curve. The Dr. 1 was fresh out of fellowship. So while surgery fellowship is 5 years as a pediatric or as a surgical fellow and 2 years as a pediatric surgeon, this was their first job as an attending doing these surgeries, versus Dr. 4 has now retired from practice. So older, wiser, and less painful was the conclusion. We were looking for modifiable factors or things that we could predict. I don't know if I want to be able to predict for patients which doctor has the less pain. I'm certainly not putting on a Yelp rating or anything like that. One of the other items that I had asked them to look at was we got the patient's prediction of how painful it was. Now, we say with both of these surgeries, these are the most painful surgeries that we do to children. We tell the parents that none of these surgeries are done immediately. It is typically, you've had several preoperative visits to go over the risks, the benefits. Do you really want this procedure done? Because it's a big procedure to put hardware on a child. And so we collected from the parents and from the child the day before their surgery, how painful do you think this is going to be? And this is on a 0 to 100, what we call it a visual analog scale. They're giving a line with the left anchor being no pain and the right anchor at 100 millimeters being the worst possible pain. And they mark with a vertical line across that, across where they think their pain is going to be. We did this also because Logan et al. Had concluded that if patients predicted that they were going to have a lot of pain, then they actually postoperatively had a lot of pain and concluded that pain was a self-fulfilling prophecy. So this is one of the things that I had asked the team to look at.
Yes, Renee. So first we looked at just the relationship between parent and patient predicted score. We were wondering if this perhaps catastrophizing or self-fulfilling prophecy would be related between the parent and the patient. And we found it to be mildly predictive. Again, you can see the R-squared 0.12 on a scale of 0 to 1. So not too strong, but the p-value was significant. Maybe not something, we would publish, but we were very curious to see how this would break up by cluster of increasing, decreasing, and high variance pain patients. And that's what you can see here. So by cluster, you can see decreasing high variance and increasing pain, and the parent predicted is there in blue and the patient predicted in orange. And what we first noticed from this visual is simply that, okay, the parents always predict higher than the patient. Maybe that makes sense. Parents are a little bit worried for their children. And then what surprised us was the highest predicted pain score for both the parents and the adolescents are actually from the decreasing pain cluster. So this is not really a self-fulfilling prophecy. In fact, it's the opposite from what Logan found.
One of the other things that they were interested in, and I know Naomi specifically is really interested in, is other than medications, what can we use? And so we had done some studies previously with the patients who had pectus excavatum or the NUSP procedure, the chest procedure that we talk about, using self-hypnosis, where they were taught how to hypnotize themselves, which, by the way, the people who do this will tell you that all hypnosis is self-hypnosis. They cannot make you quack like a duck if you don't want to quack like a duck. I don't know, perhaps I am quacking like a duck and I'm not even aware of it, but that's what they tell me. So it's all self-hypnosis. This was a technique that we were teaching patients and then looked to see if it made a difference. We had previously shown with the NUSP patients that self-hypnosis alone was decreasing their morphine use by 0.5 milligrams an hour. 0.5 milligrams an hour is a huge amount of a difference. And where it's really important is the morphine or the opioids were being given by self-medicating. The patients had on their IV a button computerized device called patient-controlled analgesia. When you're hurting and you think you need something, you push the button, you give yourself the medication. So you can see where if they're also using other self-hypnosis techniques to manage their pain, where they may not need to push that button as often, and in reality, they got a lot less pain medication. And we did 2 different studies looking at the effects of self-hypnosis, and obviously very powerful. So this was something that I had shared with the students, and they wanted to look at whether it made a difference with specifically our patients who had spinal fusion, because we had not looked at those patients before.
So here we ran a quick linear regression to see if we could predict the spine pain in the 0 to 72 hours window. And we did find some predictors significant here. So the way that linear regression is typically evaluated is by looking at the R-squared here, and of course the ever debated p-value to determine the statistical significance. So here you can see we've looked at the adjusted R-squared, which is just a modified R-squared to adjust for the number of predictors, and it's 0.3, which is pretty good in this realm of scientific journal publications to look at, as well as the p-value is significant around a 0.05 threshold. So looking at the predictors that the model found significant, we see self-hypnosis and massage did come up, as well as parent-predicted patient pain. So what does this mean? Well, if we look at the coefficient of these predictors, we see that they're both negative. So what does a negative coefficient mean? It simply means that as the independent variable increases, so the self-hypnosis here or the parent-predicted pain, the dependent variable would decrease, so pain in this case. So now that we know about this, we thought we can focus on the mitigation plans and prep. Looking at the aggregate data in time series, we just noticed a spike around 48 hours, and we thought, what could be happening here? Could we use massage as a mitigation opportunity? I'll let Renee shed more on the clinical treatment.
And this is what I loved, is the fact that they had that unbiased look. They were immediately saying, gosh, look at what else we see. Can we do this? Could this perhaps help your patients? And that innovativeness of doing it. What they didn't know, and this is why I always like to emphasize that clinical analytic partnership, is that something very important happens to the patients at 48 hours. At this time with this data, that's when we were first getting these patients up out of bed and removing their epidural. So the patients may have thought at 0 to 12, 13 to 24, 25 to 36, 37 to 48 hours that they were in pain. They may have thought that their epidural wasn't working very well, but boy, at 49 to 60 hours when the epidural is gone and we say, all right, now get up and walk, they may have been wishing to get back in that bed and to have that epidural back. Now, I do like to point out, though, that these pain scores were on a 0 to 10 range, and the difference is only 0.4. We consider 1 a clinically significant, but it is obvious with this visual that there is a change at that 49 to 60 hours. And while I would love to, as they got up out of bed, provide them massage or tell them to use hypnosis and think that would work, we're doing something completely different. What we decided to do instead is get them up sooner, get them up at that 0 to 12 hours, get them moving. This is something we found works very well with our chronic pain patients. It hurts to move, but we get them to move more. They hurt less. So why are we not doing this with our surgical patients? And we'll let you know in about 2 years when this conference is virtual again, right? How we're doing and if that's made a difference. But the important thing that I want to emphasize is that clinical academic partnership. They looked at the data in a different way, and they were able to bring these insights that absolutely helped to say, gosh, maybe we should do this. It got us to emphasize we need to do self-hypnosis training with more of the patients. I don't want to see a difference between those who got it and those who don't, if everybody has access to it. And making sure, though, that we're not just looking at the data, but we're thinking what else is going on with those patients.
Exactly. And from a technical analytics standpoint, Renee, we also had many insights and learnings, the power of viewing patient pain in this time series format, doing clustering for more meaningful segmentation. And I think just in general, this holistic kind of data and analytics approach, looking at visual analytics as well as statistical significance, more important, especially in the exploratory phase when we want to test several things without maybe focusing on the final p-value. So a lot of insights, but also many more questions arose from this, and many more ideas came to us from a technical solution standpoint. So we'll move right along into some of the current work we've been doing this summer, expanding some of these initial insights and expanding them to other patient populations as well. So I'll turn it over to Trishla, a data scientist from our Kavi Labs team, who will share the results. But first, a quick word from Renee on our new patient population, the appendectomy.
So appendectomy is a far more common procedure. It is the most common, in fact, emergent surgical procedure done on kids. We do it mostly laparoscopically. It's very rare that it's not done laparoscopically at this point. And most patients, I remember when I started in clinical practice 30-something years ago, patients stayed in the hospital for 14 days. They now go home in less than 24 hours, unless they are really, really sick. And that tends to be our younger patients. So this is the procedure we're talking about. We had enrolled 100 patients in this study. 96 of them went home with opioids. And as it says in the title, did we start the opioid epidemic? This was one of our ways of looking at what's happening at home, the big black box of what is happening at home. What are people doing? How much pain are they having? And really, this had never been described before. And so it's been a great partnering with the Kavi Labs team to look at these patients. We only have data on 49 patients. Why? Because sometimes when you send things like opioids into the big black box of the home, they don't come back and people don't tell you what's happening. But we did have at least 49 people who gave us results. And this is Trishla. And one of the things that as I said before, people look at means, medians, and the first time she showed me this chart, which is a little complicated, I fell in love with it. So I'm going to let her explain it to you.
So thank you, Renee. So when Renee gave us this data set that had pain scores recorded by about 49 patients multiple times in a day for about 14 days, the first thing that we wanted to look at was the trend in these pain scores across all these 14 days. Now you can see the reds here highlight a lot of pain, maximum pain, and the greens are for less pain or minimal pain. Now, by looking at this graph, the first thing that we noticed was the shift on day 5. This is day 5, and we see a shift happening in the pain scores on this particular day. So it goes from more reds to more greens. So what we concluded here was that until day 5, patients experience a lot of pain. Day 6 onwards, the pain scores start to drop or go down. Now, after looking at that, the next thing that we wanted to analyze was the trend in the interventions taken by these patients across all these 14 days. As you can see here, the various forms of interventions that were provided for reducing pain in these patients was hydrocodone, oxycodone, non-steroidal modes such as ibuprofen, and they were also asked to record any other meals that they have taken for these 14 days. And what we found out was, again, until day 5, the use of opioids is dominating.
Right.
It may be primarily because of the maximum amount of pain that they've been experiencing here. So Renee would like to compare our research findings with one of the guidelines CDC has recommended for opioid usage among such patients.
Right, about this time, the CDC came out with guidelines, and yes, it's the same CDC that is looking at the COVID epidemic, so the opioid epidemic, they're in charge of epidemics, but they had put out guidelines on chronic pain management in adults. And in it, they made a comment, not an evidence-based comment, but a comment where they said, you know, this is only about acute pain and only about adults, not about, or this is only about chronic pain, not acute pain, because acute pain only lasts for about 1 to 3 days. And people only need opioids for about 1 to 3 days after acute pain. And every once in a while, but very rarely, somebody might need an opioid for 5 to 7 days. So you can imagine me as a clinician going, wait a second, what's going to happen to the kids now that they have this guidelines and they made this non-evidence-based comment, what with those pectus patients, with those scoliosis patients who we knew were taking opioids for up to 2 weeks. And now the CDC has said nobody needs opioids for that long, actually only 1 to 3 days. And what you see here is that the patients were using opioids. The blue is oxycodone, which is the most common opioid that was prescribed. They were using it all the way up to 11 days after surgery. yes, the majority were only using it for 1 to 3 days, but we still see a good deal of patients using oxycodone to treat their severe pain at days 5, 6, 7, and beyond.
That's right, Renee. So now, after looking at the trend in the interventions used by these patients for all these 14 days, we wanted to see for what level of pain, which medication is being mostly taken by these patients. Now, as you can see in the graph, for severe pain in the range of 3 to 5, most patients have been taking hydrocodone and oxycodone, which are opioids. And for lesser pain, these patients will be taking ibuprofen. Now, some patients have also recorded usage of stool softener and famotidine, which are not necessarily painkillers. And then others have also recorded usage of ice and heating pad to treat their mild to severe pain.
And that was surprising to me how many patients put in medications that were not really pain medications, but that's what they were using at home. It certainly makes you wonder what else they were using that weren't reporting. And remember, we have no data on 51 of the patients who didn't return data.
Right. Okay, and now one last thing that we wanted to look at was, we had a question whether these forms of interventions have been effective as painkillers or not. And to do that, we asked these patients to record their pain scores before and 1 hour after taking the medicines. And you can see mostly the change in the pain scores is negative, which means the pain scores have dropped, which reaffirms the fact that these forms of medications have been effective as painkillers for these patients. Now, with that finding, we wrap up our first research, and I would like to ask Renee to give you a brief overview about the second one.
Yeah, this is our Pectus patients again. And in addition to that, and I know it's very confusing, that last one was, we measured pain on a 0 to 5. In this one, we're gonna measure pain a little bit differently. We measured pain again with these patients on a 0 to 100 using that visual analog scale. And we also had them draw where their pain is. And what you see in the very top middle drawing is, this was a Pectus patient, and as I said, they have 2 poke wounds where the bar goes in on the right under the axilla. What was odd about this patient is a month later, they drew the bottom picture. And notice they're not talking about pain in their front anymore, they're talking about pain in their back. This patient, if this data had been not identified as this patient, I would have thought this was a scoliosis patient, because that's where scoliosis patients typically have. Now, the way they have traditionally analyzed this data is by body surface area. You can imagine it's pretty hard for me to take a little ruler and try and figure out how much the kid has colored in, especially look at the difference between the colorings on the top and the colorings on the bottom. How do you measure all those little lines? But that's where you get body surface area. The other way they validated this tool is by looking at the number of areas. So do you really think that the patient had more pain a month later than they did? Is that really more body surface area? They have 3 sites, but as opposed to 2 sites, but they're completely different sites, and that's something that's not caught. The other thing that you may have been asked to do with your own healthcare professional is they may have asked you, if you've ever had pain, to describe the pain. And I always say, try not to, when I teach healthcare professionals, I say, try not to lead the witness. Don't say, is it sharp? Is it burning? Is it throbbing? Because especially with young kids, they'll say, yes, 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 it's all those, because those may be words they've never used before. And so we actually analyzed the words. They had 67 words to choose from. And surprising to me, there was a space for them to add more words, and they added more words. And this is the analysis of the words.
Thank you, Renee. So when Renee gave us this data set that we got from the APPT tool the patients used, we wanted to do a little more than word analysis. We also wanted to look at how the pain score, which is the body surface area, varies across all the days they have reported their scores. So what you can see here is the most frequently used emotion expressed by these patients is tight, uncomfortable, sore, etc. And the body surface area has been the least right before the surgery and maximum right after the surgery. And then on, it only decreases 2 to 4 weeks after the surgery. We did something similar for the next score, which is the visual analog score as well, and we found a very, very similar pattern. The words used, these are the top 20 most frequently used words: tight, uncomfortable, sore, dominating the list. And then we can see the VAS score, or the visual analog score, is the least right before the surgery, maximum right after the surgery. and gradually decreases in the next 2 to 4 weeks.
And the
So now-
clinically important piece of this is opioids are really not effective for tight, uncomfortable, sore, aching. If you think of when you have those types of feelings, hopefully your healthcare professional is recommending a non-steroidal or a muscle relaxant and not recommending an opioid. Opioids are great for sharp, acute pain, not great for that uncomfortable pain. And so we've really changed our treatment with these patients to de-emphasize the opioids. So now this next one, again, I just wanted to, we're going to talk, because we were just talking about pectus patients, we're going to talk about the scoliosis patients, and just to remind you what they had before and what they have after their surgery.
Right. So the third research was based on comparing the pre and post pain scores among adolescents undergoing scoliosis. So the first thing that we wanted to look at was compare the visual analog score right before the surgery and 1 month after the surgery. So we did that first for patients that had some pain before the surgery. And to do that, we did a paired t-test, the results of which came out to be significant. As you can see, there is a significant reduction in the pain scores for such patients 1 month after the surgery. Now, when we did the same thing for patients that did not report any pain before the surgery, you can see the increase in pain is significant. So all in all, what we concluded was that scoliosis is effective in reducing pain among patients that had prior pain. But for patients that did not have any prior pain, it only led to an increase in pain 1 month after. And just to bring that out, the test results were significant. Now, in this graph, what you see is the comparison of 1 month later pain scores between both the groups of patients. Now, you can see the difference is not significant based on the results of the 2-sample t-test. So we concluded that the pain experienced by both these groups of patients 1 month later is almost the same. Now, after doing that, we wanted to see if there are other ways of categorizing these patients such that we can effectively treat, we can provide them personalized treatments based on the group that they fall in. So what you can see here is a graph that gives you 3 distinct clusters, and we did that with an algorithm called the K-means clustering. So the red group here is the group that has high pre-op and even higher post-op pain. The yellow group is the highest pre-op but lower post-op pain, and the last one is the lowest pre-op but a little higher post-op pain. Now, keep in mind that these are just the average scores that we have plotted. When we created box plots to do the same, the findings slightly changed. Now you can see 3 groups, but then in group 1, we see a good amount of reporting of pre-op scores and then an increased reporting 1 month later. For group 2, we have a high amount of pain right before the surgery and the pain scores go down 1 month later. But in the last group, you can see that the pain scores are almost the same before and after the surgery. So based on this, we concluded that we can provide treatment based on the cluster a patient falls in. Now with that, we wrap up our last research as well, and Renee would like to share the conclusions that we had from all our research papers.
So hopefully one of the things we've emphasized that pain is more than a number. And so I apologize when you go to your healthcare provider and they say on a scale of 0 to 10, how much is your pain? First of all, that's 11 choices. That's too many choices for anybody. All we need to know is, are you having pain? And typically if you're at your healthcare provider to talk about it, it's severe enough that we should be doing something to help you relieve your pain. But where visual analytics was really important to break down that pain so that we could do something that was treatment related, that was effective. So one of the several limitations came up as we were doing this research. And one of the things that was great about working with first the Northwestern students and then with Kavi Labs was I brought this data, and as they looked at these things, they came up with these incredibly innovative ideas that I didn't even know could be done. And so brought in the rest of the Kavi Global team to really talk about some other things that you may apply. And the first one, I'm going to let Naomi introduce, but it's the fact that I had these horrible handwritten documents that had to be interpreted, analyzed, and put into a database before they could be analyzed. I don't imagine that anybody at a children's hospital has handwritten documents that they need to do something about and that they bring to your data analytics team?
Yes, thank you, Renee. So we did face this challenge that many others do, even in our research, of this manually collected APPT Word data. So for the Pectus patients, we use the APP tool, and it's a great tool, some great information here for analysis, but we really want it to be collected in a digital first format so that it's readily available for analysis and doesn't require the manual time to prep it. So here we were fortunate, we had a small sample, so we were able to take the help of, I think, Renee's summer intern, but even she had to spend 1 week just to digitize 330 data points for 22 patients. So a cool, just different analytical solution that we wanted to show you if you do need to do this at scale is a use case that we've delivered for another client, but has a parallel in healthcare using optical character recognition, or basically the ability to kind of digitize your documents. So here, we see having data not accessible in a PDF format is huge across industries. Trishla, if you can just go back one slide. So we wanted to share with you this historical data digitization solution that we built for an industrial client. So here our client had thousands of assets in the refinery or machines, and each of these assets had decades of information related to the specification, the performance, the maintenance history that had been done on it, and all these several millions of pages across different locations were these analog documents, not stored in any grouping, not classified, and basically not accessible to the operational personnel or the decision makers that need to be working on those assets to have access to in a timely manner. So this is very similar to the healthcare parallel, where we might have lots of different types of patient historical documentation, written prescriptions, that is not available when a doctor is at the time of care. So here we present a solution that is applicable across industry. On the next slide, you can see the high level architecture and output of our solution. A machine learning solution using Google Cloud platform text recognition. So we read in all these different documents, over 500,000 pages were digitized, and we were able to train and classify a model to basically make that categorization. Is it a maintenance document? Is it a specification? Is it something else, right? And we were able to do that classification with 100% accuracy. So that's great. Then we were also able, in some of the documents, they had handwritten notes. We were able to extract that out with about 80% accuracy. So hopefully we can maintain that 80% accuracy when we try to do this on doctors' notes. I know they have some challenging handwriting, but we'll see. And on the next limitation, I'll let Renee chime in.
Yeah, so this is great that the patients we studied before could all self-report their pain, and you saw the difference between what their parents said and what they said, and these parents had been around these kids for at least 10 years. But what about our younger kids, our more vulnerable kids who have difficulty communicating their pain? Now I'm going to take a brief moment to have you decide, is this patient in pain or not? And I'm going to give you some clues. We know that the facial expressions are most closely matched to brain functional MRI, brain images of pain. So we should be able to tell from the face whether the patient is having pain or not. This is a Lurie Children's patient who had open heart surgery, as you can see from her nice little sternotomy incision. And when a baby is in pain, a child less than 3 is in pain, they will have their eyes tightly closed. You'll see a furrow between their brow. Their brow should be bulging. Their nose should be bulging. You should see a very deep nasolabial fold, and their mouth should be open, wide, and square. So, do you think this baby is in pain? So if you had the experience that I did, where you got to see video, okay, maybe it was like film strips back then of shot after shot after shot, you would easily be able to say that this baby is not in pain. Why? The mouth is round. It is not square. And the other thing that I didn't tell you is the tongue is supposed to be very taut, and her tongue is kind of loose. So she's just pissed and didn't want her picture taken, I guess, here at Lurie Children's. But can you imagine, we have how many nurses looking at these kids trying to determine if this is a pain face or if this is I'm a mad face. They don't know the child as well. And so when I was bringing this up to Naomi, she said, oh, well, we could pick this up, and let me tell you about this great project that we did that picks this up. And this is where we're going to be famous someday. So now that it's been shown, you guys can't steal our idea.
Thanks, Renee. Yeah, let me share a little bit about a technique using what we call computer vision video analytics that we thought a similar approach could be leveraged to detect facial action units, or those different facial expressions that you were explaining, to classify pain in those neonatals or nonverbal populations that we're also interested in. So here is a use case where we were partnering with a university researcher who wanted to study dysphagia, which is a difficulty in chewing or swallowing, which of course impacts your quality of health and life, leading to malnutrition, dehydration, et cetera. So previously, the researchers used to do this analysis manually, but it took far too long. So they asked us, is there a way to leverage computer vision to automatically identify sensors that are embedded into the facial muscles of these mice, generate the data, and then analyze that for correlations? So the team that worked on this was able to drive 300 times improvement compared to the manual process of video analytics encoding that those researchers were doing. And a quick overview of the algorithm approach here in 5 steps is it reads the data in frame by frame. So it's a video, so each frame is a snapshot as an image. It reads it in. As you can imagine, there's a lot of movement. So we use a neural network to identify the bounding box to really get the head and the markers in position. Then employ some Kalman filters along a Hungarian algorithm to keep track of the markers from frame to frame. And there's some sequence matching that needs to come up to align the left and the right cameras to then convert this 2D into the 3D representation that we had. So very exciting work, and hope that we can apply similar things to Renee's research for the nonverbal and neonatal pain classification. And the third limitation we quickly wanted to touch on is, again, for the spine and NUS surgery, patients were filling their pain in these body outline forms manually, and they're normally processed by looking at the number of the site and quantifying the surface area. But remember, pain is so much more than a number, and this two-dimensional figure certainly doesn't represent their pain or show the change easily over time. So here our go-forward recommendation is to digitize your input data collection with a smart app, and that smart app could include a variety of important pain factors like pain intensity, the location and the quality, different pain inferences like what daily activities or mood or what is their quality of life impact, and then also some aggravating and alleviating factors. So now that we know smart apps can help us on the input data collection, I'll turn it over to Parthy for a 1-minute case study overview on how they can also help for better medication adherence monitoring.
Thanks, Naomi. Here's a project which is called Transform Diabetes Care, where we utilize smart apps and real-time data to look at the patients who are suffering from diabetes or at the risk of diabetes. The program was designed to help reduce the complexity among patients, to reduce the self-management that's involved in the process, and also to bring some health outcomes which could improve their medications. The program basically required building an analytic engine that would analyze the pharmacy claims, the medical claims, as well as the drug codes. So this helped us to identify the eligible members who have diabetes or those who are at risk. So once the members are being identified, the members were then enrolled in a program, and then they were given a glucometer device along with some test strips. So the member then syncs the blood glucose readings from that device. It's then transferred real time through a staging table through an API. And then what we do is we store that in a data exchange layer, and then it's then consumed for data analytics and reporting. So how we used advanced analytics has really used this real-time data, and then provide some personalized support to these patients, and also help them in coaching them to manage their medications as well. So
okay. You know, this is Jennifer. I'm sorry, we're at time. Thank you very much. I want to open it up to the audience to see what questions we have about the project having to do with the work that Renee and her team were doing on pain analysis. So, and kind of I think the really interesting hypothesis of how you use visualizations to explore things that really quantitative methods don't so easily allow you to explore. So I would invite any questions we have on the presentation. Ashley, Amanda's having a poor, it doesn't have stable internet. So if you could read the questions, if we have any.
Of course, we do have a few. So first, were the time points for the pain scores the same for all patients, i.e. the same count/interval? And how was cross-correlation summarized into a single similarity measure for clustering?
So yes, they were. We actually had the data for every time the patient reported pain when they were in the hospital, and then reduced that to actually the mean, the maximum, the mode, the median, and I gave the students all of those, and then Naomi can address the cross-correlation.
Yes, so we just fed in those values that you saw there on the 2D matrix. So cross-correlation is just the similarity between the two time series functions. A dot product for the displacement was related to each other.
Yeah, I mean, cross-correlation usually is calculated against multiple lags. So I was asking whether you took the maximum of the multiple lags or whether you just took the 0 lag correlation.
Oh, I'm not sure off the top of my head. We might have to go back in the code because there was a Northwestern team group research on this, but I can definitely check and follow up with you.
Okay.
Next is also from Michael. He says, I saw a cut point for a 5 cluster model. Did you try that out to see what those clusters looked like?
Yes, we did run through for a variety of different clustering, and we looked at the 3D plots to evaluate the separation as well as the time series that were grouped together. And I think three was the most meaningful and made the most sense and had kind of the most distinct separations.
What's the diurnal variation in the opioid use count?
Can you repeat that, Ashley?
So in the opioid graph, I can just do it. In the opioid graph, opioid histogram, the daily usage levels.
Yeah.
There, back.
No,
back one.
Next one. Next one.
There.
That one. That
yeah,
one.
So that diurnal variation, is that just people waking up and feeling more pain? And then over the course of the day, why is there a decreasing line?
Great question. So what you'll see is that it says day 1, time 1. So that's the first time a patient. Now, some patients, it may have been first thing in the morning, 5 o'clock in the morning, or even 1 o'clock in the morning. And some patients may not have done anything for pain or reported that they had pain till 7 o'clock at night.
Oh,
but what you'll see, but what you'll see is then the second time, that's if the patient had a second time. So you have a lot of patients who did something once, less patients who did something twice, far less patients who did something 4 times. And what you'll also see is when you get farther out, how many days out, you have less interventions. Now, where this was important to me is your opioids last for 4 hours. And I know many of you have gotten prescriptions that say 4 to 6 hours. Well, unless you are a very poor metabolizer, and we can genetically test for that, they're not going to last for 6 hours. Yet there were very few patients who was taking something 6 times a day. But I think that fits with pain. Do you have more pain when you're moving more? Do you have pain when you're sleeping and you roll over, and does it disturb your sleep? You're not medicating for that acute pain 100% of the time. And what we're trying to get is the pattern of what people were doing for what degree of pain and how was it affecting their life. And how could we better advise how many of these pills do we send home with these patients? Would this give us that information? Obviously, I still don't want to send home 11 days worth of medicines for everybody because I only have very few patients who are using 11 days worth of opioids. But I'm nervous that if I send nothing home or if I only send 3 days home, what happens to that patient? And what happens to their function? And we know that poorly controlled acute pain ends up being chronic pain. And what happens to them as a functional human being at that point? Does that answer your question on why those weird, yeah. It is one of the graphs that we didn't show is where Trishla actually put all of the pain scores and, so that you could see, is it that they have higher pain in the morning than they do in the evening, or what are those types of things? And I apologize, we didn't put that one in there, but it's one of them that we shared with one of the surgeons, and first he was confused, and then he was like, okay, you're right, Renee, that's really cool, and that needs to be published.
Okay. Do you have concerns about losing any qualitative data or reduced participant comfort with digital data collection instead of paper?
I do because, but it's one of the things that I studied the genetics of pain and analgesic metabolism, and I'm amazed at how many people are willing to give me their genetic specimen, but they're not willing to tell me how many opioids they used. And certainly with the opioid epidemic, one of the things I wonder is, are they concerned that, then we will say, gosh, if you're not using them, we want them back, or you have to return them. And are they fearful that they're not going to get them? So, while I think, gosh, you're giving me your genetic information, which gives me a whole lot of information about you. And I've literally, knock on wood, had only one patient in the 10 years I've been studying genetics tell me that they wouldn't give me genetic information. Is it because we have a generation that's used to using apps and social media? Would we be better off collecting that type of data? With the opioid use, we did use what's called ECAPs. At that time, they had to bring the pill bottle back so that I could download how many opioids were used. At this point, I don't have to bring it back. If they have their smartphone on and it's close to their smartphone, it can give me that information. But as with the diabetes model, gosh, but then what do you do with it? Do I call them and say, you're 2 months out of surgery and I noticed your ECAP of your oxycodone was opened? What are you doing? Do I send the police? What do I do about that? We haven't quite figured that out. And actually Naomi is part of is on an ethics, you'll have to explain it, an ethics journal, looking at what are we doing with this information? And I tell her, great, when you decide, would you let me know? I'm going to experiment it with it first and see what patients will do. But I think social media has made it so that we do have a generation that they'll share a lot of information with us. That me as a fairly new grandmother, I'm a little nervous about sharing that kind of information, and I can respect that with my patients. Does that answer that question, Ashley?
I think so, yeah.
Ashley, I think we have time for one more quick question.
Okay, there was only one left, and they were, what different software tools did you use for what you showed in the seminar, the cluster analysis, text mining, visualization, etc.?
Yes, some of it was done in R, some of it was done in Python, and the visuals from this summer were created in Tableau. So 2R coding by hand, R in Python, and then Tableau is a kind of visualization tool, more drag and drop.
Great. Well, thank you guys so much. Really appreciate the presentation. Great work. Really interesting. Thanks so much for sharing it with us. Everyone else, have a great day and enjoy your Labor Day weekend.
Great.
Take care.
Thanks.
Thank you all.
Thank you, everyone.
Thank you.